Thanks a lot. Thank you very much. And thank you for the kind invitation to speak. But Seattle is a tough town because they say 30 minutes. I'm already down to 27:53. This is tough. This is tough. Seattle is, I was asked to talk about maternal-fetal conflict, which we will, but that's too short a title, so I gave it this long title, which you see here before you. And we're going to talk about maternal-fetal conflict for a bit. But first I want to acknowledge the hosts, Ben and Doug, and everyone else who've been so kind. And for those of you who are here visiting, there's no question that Seattle is the epicenter of pediatric bioethics for two reasons. One is the Truman Katz Center. That's the secondary reason. The first reason is that one of the godfathers of medical ethics actually is from the Seattle area, and in one picture actually summed up the entire field of medical ethics. And you guys are probably familiar with this. This is basically all the time you spend studying. Now this is my talk, and now the rest is just kind of filling it in, okay? It's either one or the other. I'd like to start with a question, please. And the question is it possible to have an obligation to someone not yet born? Some would say that those of us who would be parents have an obligation to prepare for and care for our young, our children, long before they're hatched. The philosopher Bonnie Steinbach is among them. She says that just as parents have obligations to avoid exposing born children to risks of serious harm, pregnant women have comparable obligations to the children they will bear. She's speaking specifically about their future children. And so she does not speak in her writings about obligations to fetuses, but rather to the future children. And she feels that the pregnant woman, indeed both parents, carry an obligation to the future children. But she cautions us to balance those obligations against other obligations and interests, and against the violation of women's rights, and we'll talk about that a bit. In particular, against the dangerous concept of seeing the pregnant woman as simply a fetal container. So before we get through this, I want to talk a little bit about professional humility, which includes, among other things, recognizing what we don't know. So we're speaking about areas where pregnant women choose not to follow medical advice that we feel is important for either their welfare or for the welfare of the fetus in particular. Two pieces of data. One from the lower one, actually, from 1987, comments that 1/3 of medical interventions over maternal objection were subsequently medically proven wrong in retrospect. On the other hand, a more recent publication shows refusal of a medically indicated intervention is an independent risk factor for perinatal mortality. So I think that these two studies combined pretty much prove that we used to get it wrong, but we don't anymore. Yeah, we do. For those, if there's anybody out there that doesn't realize, we sometimes get it wrong, and we need to go into these problems recognizing that as far as prognosis, we sometimes get it wrong. Now, here are some of the possible issues we face with maternal-fetal conflict. The use of alcohol or illegal drugs, poor compliance with a recommended regimen, such as digoxin for SVT in the fetus, HIV medications, a diabetic regimen, and so on, leaving the hospital against medical advice. And the fourth is refusal of a procedure such as transfusions, in utero transfusions, or a cesarean section. And I want to concentrate on the fourth, which is, I think, the most dramatic and probably the most invasive of things we might choose to do for a pregnant woman. But hopeful that the ideas that come forth in the discussion about cesarean section over a woman's objections, the ideas that come from that conversation should be applicable to the other problems listed here as well as others that may come up. So here's a case to consider. A woman is in labor at term. There is severe fetal bradycardia, and the woman refuses cesarean section. The obstetrician fears fetal death or permanent neurologic sequelae in the future child. Is it ethically acceptable to operate, or is it acceptable, should he or she operate without the woman's consent? So the idea of doing surgery without patient's consent is an issue that many people thought we resolved long ago. The famous jurist, who I think has already been quoted once today, Benjamin Cardozo, says that every human being of adult years and sound mind has a right to determine what shall be done with his body. It's interesting, this ruling was a case about a woman who had surgery without giving consent, but the ruling says a right to determine what shall be done with his body. A surgeon who performs an operation without his patient's consent commits an assault for which he is liable in damage. Now, this is the early part liable in damages. So this is a ruling from the early 20th century, but the idea that people get to decide what will and won't happen to their body obviously predates this. And then perhaps the most famous quote about this is from John Stuart Mill, where he said, "The only purpose for which power can be rightfully exercised over any member of a civilized community against his will is to prevent harm to others. His own good, either physical or moral, is not sufficient warrant. Over himself, over his own body and mind, the individual is sovereign." There's two things to think about. This is from the late 1800s. One is, there's John Stuart Mill, there's Mrs. Mill, and you can just tell by the look on her face how much fun it is to be married to an ethicist. In fact, you can tell that John Stewart's thinking it's also pretty much fun to be the ethicist by the look on his face. He's thinking, I want to be a 23-year-old in 2010 and unemployed and sexually active and living in my parents' house. Nevertheless, one interesting thing to be noted is that he gives us a caveat here, which is important and very relevant to the conversation at hand, to the question at hand. We can only use we can only use force on another person is to prevent harm to others. We can do this. So is that a case which is relevant here, to prevent harm to others, the others being the fetus or the future child? One of the landmark cases with regard to this was Angela Carter, who lived in Washington, D.C., and in 1985, at 28 years old, had cancer and was dying. At 26 weeks gestation, the hospital sought court order for a cesarean section over the objection of Ms. Carter and her husband. The court approved and a cesarean section was done. And both a mother and child died shortly thereafter. After thinking about it for a while and having a chance to review this not in a rush, the Court of Appeals in D.C. issued a ruling, and some important wording came out of that. And they said that a competent woman's refusal should control in virtually all cases. They couldn't bring themselves to say all cases, so they said virtually all cases. Exceptions, if any, will be extremely rare and truly exceptional. Indeed, some may doubt that there could ever be a situation extraordinary or compelling enough to justify a massive intrusion into a person's body, such as cesarean section, against that person's will. Again, they can't quite bring themselves just to say, you can't do it. Second important case regarding forced cesarean sections was in 1994 in Illinois. Mrs. Doe, cesarean section recommended at 37 weeks for placental insufficiency. She refused the surgery for religious reasons, and the hospital sued to force the surgery. And I use this case here because of the wording of the state's attorney. He argued that the fetus was a real life being kept prisoner in its mother womb and tied to an oxygen source that is not working. It sounds similar to Professor Steinbach's warning about viewing the woman as a fetal container. She's an oxygen source, and it wasn't working out. That argument was rejected by the court. An appeals court in a later statement said quite firmly, a woman's right to refuse invasive medical treatment is not diminished during pregnancy. The potential impact on the fetus is not legally relevant, says the state of Illinois. But other cases that occurred later, one in 2004 in Utah, a woman was charged with first-degree murder for refusing cesarean section. She had twins, one was stillborn and one was positive for cocaine. She later pled guilty to 2 counts of child endangerment. In Pennsylvania, a woman who had previously given birth vaginally to 6 infants, some close to 12 pounds, refused a cesarean section for macrosomia. The hospital obtained a court order. She and her husband, according to this publication by the American College of Obstetrics and Gynecology, I love the quote, they fled to another hospital where she had a normal spontaneous vaginal delivery to a healthy 11-pound boy. I should mention in the Illinois case also, Mrs. Doe had a healthy child, never having fleeing. So what does the law say here and now? It's a difficult question. Depends on who you ask. And I don't think we should ask, at least not yet. So here we have 2 men, and if you've heard them speak on PBS, if you've written things they wrote, Justice Breyer, Justice Scalia, wherever you are politically, these men are probably both smarter than you are, and at least one of them probably says things that make sense to you. The fact is that more often than not, or very often I should say, they disagree on what the law says or what the law should say. Moreover, starting out with what does the law say with a problem like this, I think is a real mistake because it short circuits the intellectual work, the ethical work of going through an analysis to figure out what we think is right. So let's not ask what the law says yet. And in particular, don't ask me because I'm not an attorney. There are actually folks here who are and who can answer that much better than I. But let's talk about what we do at least, what perhaps we can talk about as the standard of care. This is a publication from 1987, a survey of maternal fetal medicine fellowship directors. About half, 46%, thought that women who refused medical advice and thereby endangered the life of the fetus should be detained. And about half, 47%, supported court orders for procedures such as surgery or transfusion if those procedures were felt to be the standard of care. So about half thought it was okay. They also, in that paper, reviewed court orders for cesarean section in 11 states. And it's worth noting that 81% of the women were Black, Asian, or Hispanic, and all were from teaching hospitals and or on public assistance. And the relevance of that we'll get to in a bit. The same sort of study was repeated not long after, and it was found a survey of 42 MFM fellowship directors, only 4% agreed with forcing the C-section. So in less than a generation, it would appear that the standard of care has moved considerably, where very few MFM directors now would say it is okay to force a woman to have a C-section to save the fetus. But ethics is about, let me just see if we missed something here. No, I guess not. Ethics is not about what do we do, what's the standard of care. Ethics is the study of what we ought to do. So let's see if we can, in a few minutes that we have, at least begin to frame an ethical argument to support our position. Or better yet, let's see if we can frame an ethical analysis without a particular position in mind. And let's see where it takes us. Now, as most of you in the room know, when we make ethical arguments or create an ethical analysis, we often rely on 4 standard principles. Respect for autonomy, a person's right to control what happens to their body. Beneficence, our obligation to act for the good of our patients. Justice, a complicated concept, but the foundation of which says that people deserve equal treatment unless there's a serious medical difference between them. And non-maleficence, our obligation to do no harm. Taking these in mind, considering the rights and moral obligations involved in this difficult question of forced cesarean section, we have the pregnant woman's right to autonomy. She's refusing the surgery. We might have the rights of the fetus to beneficence on the part of the physician as well as on the part of the mother. Some people acknowledge the rights of the fetus, some do not, hence the question mark. The rights of the future child, Professor Steinbach's argument. Does the rights of the future child, should they be weighed into this decision? As we look at these 3, we consider what are the pregnant woman's obligations and what are our obligations, the physicians and nurses and others. And by the way, as you read these things, you realize that the physicians can't even agree, those who think about these things, how many patients we're treating. Are we treating 1 patient or 2 patients? We're talking about a woman in labor at term. We could have a similar conversation about a woman at labor at 24 weeks, and of course things change a bit. So for simplification here, we'll talk about at term. But only if I can get this to move, otherwise we're done. Okay, now, with all this in mind, smart people sat for a while and said, what's going to be our position? So the American College of Obstetrics and Gynecology Committee on Ethics said, here's our position. In the absence of extraordinary circumstances, circumstances that, in fact, the Committee on Ethics cannot currently imagine, judicial authority should not be used to implement treatment regimens aimed at protecting the fetus, for such actions violate the pregnant woman's autonomy. So there's your answer. Basically, we consider all those, we've considered those principles, and we consider all those things, and we say that basically the pregnant woman's autonomy trumps everything else. So we've done our ethical analysis, and we have the answer. But we have 13 minutes and 48 seconds left. So that's not counting the 2 that they swiped from me at the beginning. So let's look a little bit deeper, because this kind of begs the question, doesn't it? We say maternal autonomy trumps the fetal right to beneficence or the rights of the future child. What I mean by it begs the question is it takes as a given a premise that really hasn't been proven or shown. So we say, well, the reason why we can't do the C-section is because maternal autonomy trumps the other needs. The question is, well, how did we come to that conclusion? Where did that come from? Let's look a little bit. I would suggest to you there's two possible justifications, two possible reasons why maternal autonomy should trump, and there may be others as well. The first would have to do with moral status, and this actually gets a little bit into some of the stuff that Annie was talking about today, which is really fascinating. Moral status is a consideration of how much someone's interests should count. And we hope that all of us in this room would be accorded similar or the same moral status in a difficult question. But does a fetus have the same moral status? Does a newborn have the same moral status? One of the concerns from Annie's work, which is very important and widely looked at, is that maybe this indicates we don't really see that not just fetuses, but premature babies or brand new babies aren't accorded the same moral status as older children. So maybe that fetus or that future child is not given the same moral status as the woman, and therefore maternal autonomy trumps. That's a complicated issue, an interesting one, and it may be part of the justification. But for today, I want to concentrate on the second, which is justice. Again, at its basis, meaning that equals should be treated equally. Are pregnant women who are forced to undergo cesarean section being denied equal treatment? Think about analogous cases, such as forced donation of blood or bone marrow or kidney. Would we require a mother or father of a 1-month-old child or a 2-year-old child to undergo surgery to save that child? And if the answer is no, then how do we justify requiring a pregnant woman to undergo surgery to save a term fetus or her future child? So I'm not saying which we should or shouldn't do. What I'm saying is that we've got to have some measure of justice in how we approach this. And it may be that these forced cesarean sections are an example of unjust treatment of pregnant women. Now, there's another possibility, which is that all these principles, autonomy, beneficence, justice, non-maleficence, which we all have beat into our heads in our basic ethics classes, aren't necessarily the way to look at this. There is another school of thought, there are many schools of thought, but there is one that is particularly relevant to this question, that of feminist ethics. Feminist ethics, at its basis, says that there are perhaps different ways of looking at things. Not perhaps, there are different ways of looking at things, not based on conventional moral principles such as autonomy. What really matters more is the web of relationships, a relationship-based ethics. And this is a picture of Carol Gilligan, who wrote one of the first books to really lay this out in a fascinating way. It's an easy read and a terrific read in a different voice. But there are many others that have joined her in this, saying it's not about trying to apply these principles. My own mentor in graduate school said that's cookie-cutter ethics, taking those principles. It's a bit more subtle than that. Feminist ethics is also about ameliorating the unfair treatment of women or any oppressed group, but particularly women. Well, is that maybe so relevant to the fact that when we do force cesarean sections, or perhaps other things, keeping a woman who wants to sign out AMA, other sorts of things, does it tend to be more often than not people who are more oppressed in our society in general? That seems to be the case from some of the people who have looked back at these cases. It also relates to how pregnant women may be treated differently than others without adequate justification. We talked about that. But there's still another component, and I don't mean to simplify feminist ethics into 2 slides, but there's another component of this analysis. If we're willing to say that it's not all about 4 principles, what this ethical analysis does require us to realize is that it's about relationships, but it's about relationships and responsibilities. So here's a question, speaking of relationships. Do special relationships yield special obligations? I would suggest to you that most of you believe that's true. And it's not just about mothers and babies. It's about both parents. It's about parents of the kid. It's about, does this guy have an obligation to make sure that his parents are living a reasonable life, to make sure that they're well-fed and well-clothed, and so on and so forth? Do we have an obligation to take care of our brothers and sisters-in-laws and all the rest? At some level, depending on our closeness, special relationships do carry with them special obligations. Few of us would say that our obligation to our children is the same as our obligation to a child living 2,000 miles away who we've never met. We may have obligations to that second child, but they're not as strong. So I would suggest to you that an analysis of the question of maternal-fetal conflict using feminist ethics does not eliminate the issue of maternal obligation. Quite the opposite. Now, an obstetrician at University of Michigan named Lisa Harris has looked at this, and she said that even using the term maternal-fetal conflict is the wrong way to go. And others have said this too. We should call it maternal-fetal relationships. We should focus on how the interests of the mother and the fetus are so interdependent that we shouldn't look at it about conflict. And in fact, when we look at it as a conflict, this has a tendency to perpetuate social inequalities, as we saw in the Calder study back in '87. And I think she's right. I think it's important to keep that in mind. But I would suggest to you the truth is sometimes the woman, the mother, will make a choice that is clearly opposed to the interests of the future child. And we're going to have to figure out what to do in those situations. Now, is force ever justified? We're talking about the cesarean section, but we can also talk about the other things, like the woman who's having some fetal distress and she says, I'm out of here, and she leaves. And so many other situations that you may have encountered in your practice. Is force ever justified, or is maternal autonomy absolute? We have accepted maternal autonomy. We have basically, as a profession, and I think reasonably so, I'm right there with you, that maternal autonomy trumps those other considerations. But here's an interesting question, a thought experiment. Right here at the Truman Katz Center, we've developed, we'll call it the Seattle shot. And the Seattle shot is one sub-Q injection of a woman in labor who's having severe fetal decelerations. And it will save this fetus from death or a lifetime of severe disability. The question is, if we agree we would not force this woman to have a cesarean section, as the ACOG has said, and as other organizations have said, are we willing to give her the shot over her objection? When I've had this conversation with students or fellows, etc., nobody wants to do the C-section over the woman's objection. As far as the Seattle shot, yeah, several people say, one shot and I'll save a child a lifetime of living with severe brain damage? Yeah. Again, we can talk in theory like Annie says. We talk in paper, that's one thing. Seeing the kids is something else. But you guys still don't want to do it because you're hardcore autonomy trumps kind of people, and I respect that. I admire that. But now, forget about the Seattle shot, because we have, back in Connecticut, the Connecticut cream. What do we have to do with the Connecticut cream? We just take it, it's totally painless, SPF 30, summertime, and we rub it like that, done. And that will save the child from a lifetime of brain damage or from fetal death, fetal demise. We do this to this woman in labor with severe fetal bradycardia. Now, she has refused it. I don't want the Connecticut cream. By the way, you may not know this, but Connecticut cream has been studied for years, and it has shown no side effects, and it's totally painless. So the question is, can we use that to save this child from a lifetime of severe disability? And the answer is that there's really no such thing. But the answer also is that if you say yes, then you, my friends, have said there is some threshold beyond which maternal autonomy does not trump. When it comes to doing significant surgical procedure and cutting somebody's body open, absolutely, you're right there with Judge Cardozo. You can't do it. And with the ACOG and everyone else. When it comes to just rubbing a little cream on one person's shoulder to save another person from a lifetime of disability, that gets tougher. It's interesting. So I put you through this ridiculous thought experiment only to point out that we, as a profession, have accepted that maternal autonomy trumps, and I think it does. But there may be some threshold where we're not so sure. So at this point, it becomes up to you. We have to do an ethical analysis of the question. And the ethical analysis, I believe, should consider the rights, the relationships, the obligation, justice and fairness to pregnant women, and also it should consider thresholds, rather than just a one-sentence answer. We don't do this because it's the standard of care. We don't do this because it's against the law. We don't do this because autonomy trumps. Really, does autonomy always trump? If you guys are going out to buy stock in Connecticut cream, then you don't really believe autonomy always trumps. Now, the legal question is terribly important as well. It's terribly important, and I think we need to pursue it. But I don't think we should get it confused with the ethical analysis or with just a standard of care pronouncement. Now, if we decide we're going to let the courts decide what's right or wrong, if you decide that, where are you going to be when the law changes tomorrow? You're going to change your mind on what's right or wrong. And then when the law changes back the next day, as could certainly happen. Or where are you going to be when you cross the state line from South Carolina into North Carolina? Because in some of these issues, particularly related to illegal drug use in pregnancy, the laws are very different in those places. They're very different from there and where you live. So I do think that finally we come to the legal question, and I think it's terribly important. And the answer to the legal question lies with an attorney where you live, a healthcare attorney where you live, because the law, this is a big country with 50 different states and other areas, and it's complicated. And I can't give you that answer per se. What I would say is, I think your decision on what you think is right should include a mix of some of these things I talked about and perhaps other things you think are important to the analysis. But I think it's a huge mistake to simply abdicate that whole judgment to the legal analysis. Lastly, I would just point out that, by the way, as most of you know, we're talking about the 1%. And the 99% solution is communication and empathy. And by taking our time, as time is allowed, to try and figure out what is going on with the woman who we're having this difficulty with, who's having a difficulty, is she having it or are we having it? By spending the time, we may discover, we may come to understand why she's making what we consider a bad decision. Or we may come to realize that, in fact, her decision for her situation, etc., might be reasonable, and maybe we should yield. The communication shouldn't be carried out with the understanding that we clearly have it right, and she needs to get it right. But communication has to happen. That's 99% of the cases. These things don't come up that often for that reason. But when they do, I think we have to accept the fact that sometimes decisions are going to be made by a woman in labor that are not in the best interest of the fetus or in the best interest of the future child. Lastly, I would leave you with the thought that I do think that those of us who would be parents have an obligation to prepare for and care for our children long before they're hatched. But I would also leave you with the thought that it may well be that just because someone, in this case a pregnant woman, just because someone has a moral obligation, this does not necessarily mean that we have a right to enforce that obligation. And I thank you very much for your kind attention.